Hi friends, welcome back. Welcome back to the Nurse YouTube channel. So today we have come up with a new series which will be very important for you in your nursing career. So we will be starting a series which is named as ICU series. Okay. So in this session we will be including questions that are related to ICU setup and the emergency department settings. For example, if you are working in an ICU and if you want to attend an interview, and you can expect some questions which I am going to discuss in these sessions. Okay. And moreover, these questions will be very important, and it can be asked for other competitive exams like the upcoming Navodaya exams and all. Okay. So I strongly believe that these sessions will be very important for you, and in these sessions we will include questions from ICU setups like ventilator settings, then patient positioning for some certain conditions, then gastric ICU setups, then neurological ICU, pediatric ICU, and some positions, waste management, triage system, etc. So it's a mix up of so many important questions, and definitely it will help you a lot. So before starting our session, I request everyone who are watching our video for the first time or who have not yet subscribed our channel, kindly subscribe the channel and enable the bell icon. For that you will get the notification whenever we are uploading videos. Okay. So once again I welcome you to the our new series, that is ICU series, and this is a part 1 video of our ICU series question. And in this session I have included 15 questions which is very important. So straight away moving on to the ICU series part 1. So moving on to the first question of our ICU series part 1. Okay. So here comes your first question. So which of the following is not a method of confirming correct positioning of an endotracheal tube? Okay. So I repeat the question, which of the following is not a method of confirming correct positioning of an endotracheal tube? So this question is regarding the checking whether the endotracheal tube is in position or not. Okay. So here comes the options. The options are, the first one is end tidal carbon dioxide detector, asking patient to speak, breath sounds, and finally chest x-ray. Okay. So our question is, which is not a method of confirming the correct position of an ETT. Okay. So what is the answer? So here the answer is option number B, that is asking the patient to speak. Okay. So you know the reason that if a tube is in place, it will be difficult for the patient to speak. Okay. And moreover, endotracheal intubation requires some general anesthesia to calm the patient or sedate the patient. Okay. So checking the patient's ability to speak is not a method of confirming the position of ETT. So we will move on to the other options. That is, first one is the capnography or the carbon dioxide detector. It provides the most reliable evidence of the placement of the endotracheal tube. Okay. Capnography provides the most reliable evidence of the placement of ETT. Then another things are the clinical signs of correct ETT placement include a prompt increase in the heart rate. Okay, after intubating, the patient's heart rate will be increased, then adequate chest wall movements will be there, and confirmation of position by direct laryngoscopy, then observation of the ETT passage through the vocal cords, then presence of breath sounds in the axilla and absence of breath sounds in the epigastrium. That is, epigastrium means if the tube is placed in the esophagus and in the abdominal cavity, then there will be breath sounds in the epigastrium. So breath sound should be heard in the axilla, and we can see the with the direct laryngoscopy we can see the position of the tube, and through the observation of the ETT can also be seen through the vocal cords. Okay, and chest x-ray also is another method. Okay, so our answer here is that asking the patient to speak. Okay, so moving on to the second question of our ICU part series 1, that is first, which among the following need to be monitored for a patient received spinal anesthesia? So the question is, which among the following need to be monitored for a patient received spinal anesthesia? Okay, so patients receiving spinal anesthesia should be monitored for what? That is our question. So our options are, first one is oxygen levels, second one is hypertension, third one is renal function, and the final one is brain activity. So which among these options should be monitored for a patient receiving spinal anesthesia? Oxygen level, hypertension, renal function, or brain activity? So what is the answer? So the answer is renal function. why. Okay, we will explain why renal function need to be monitored for patients receiving spinal anesthesia. So when anesthesia is given in the spine, it is usually a local anesthesia, and definitely it will numbs the lower parts of the body. Okay, so since the lower part of the body had been anesthetized, kidney, which is also supplied by these nerve roots, may also be affected, thus monitoring renal function become very important. Understood, no? So in the spinal anesthesia, what is happening is we are anesthetizing the lower nerves. So the nerves which are supplied to the kidney also will be anesthetized, and as a result the important functions of the kidneys may not be performed. Okay, and another reason is all the toxins and the administered medicines are removed by the kidney. So if the kidneys are not functioning properly, definitely this will be accumulated and the renal function will deteriorate, and moreover the other complications also will be developed. So we have to see the renal functions of the patients who already received spinal anesthesia. I think it's clear. So moving on to our next question. Which among the following fluid is used as plasma expanders? Okay, so this question is from the fluid and electrolyte balance. Which among the following fluid is used as plasma expanders? Okay, so the options are, first option is crystalloids, the second one is colloids, third one is both option A and B, that is crystalloids and colloids, and the last option is normal saline. Okay, so crystalloids, colloids and normal saline. Which among the following is used as plasma expanders? So what is the answer? So the answer is colloids. Okay, so why colloids? You know that colloid solutions, unlike the crystalloid solutions, remain intravascular. Okay, so these colloid solutions, they will remain intravascular, or in other words, if you want to explain, they remain in our bloodstream rather than entering our cells. Okay, so they won't enter the cells and they will remain in the bloodstream itself. Okay, so this also means that they stay in your blood longer than the crystalloid solutions. Okay, so for this reason they are used as plasma expanders as a form of fluid resuscitation in cases of severe hypovolemic shock. Okay, and the last option, that is a normal saline, it is a crystalloid. Okay, they have given that option to confuse you. Okay, so understood, no? So colloid solutions, they will remain for a longer time in the blood itself and it won't enter into the cells. So there will be volume expansion will be there, plasma expansion will be there, and it can be used for the fluid resuscitation for hypovolemic shock and other conditions. Okay, so the answer is clear for you now. So moving on to the next question. The major electrolyte responsible for determining the concentration of the extracellular fluid. So the question is, which is the major electrolyte responsible for determining the concentration of the extracellular fluid? So your options are, option A potassium, second one is a phosphate, third one chloride, and the final one is sodium. So options are potassium, phosphate, chloride and sodium. So which is the major electrolyte responsible for determining the concentration of extracellular fluid? The answer is sodium. Okay, so we will see it in detail. So sodium, you know that it is the electrolyte whose level is the primary determinant of the extracellular fluid concentration. Okay, so sodium, it is a cation, that is positively charged ion, and it is the major electrolyte in the extracellular fluid. So it is responsible for maintaining the extracellular fluid volume and for the regulation of membrane potential of the cells. Okay, so our answer is sodium. Sodium is the major primary determinant of the extracellular fluid concentration and it is a cation. And other options, that is the first option was potassium. So potassium also is a cation, but it is a major electrolyte in the intracellular fluid. Okay, so from this question we are getting answer for some other questions also. So potassium is a major electrolyte in the intracellular fluid, and another electrolyte, that is phosphate, it is an anion, that is a negatively charged ion, and it is a major electrolyte in the intracellular fluid. Okay, and chloride also is an anion, and it is also present in the extracellular fluid, but to a lesser extent. Okay, not like the sodium. Okay, so chloride also is an electrolyte present in the extracellular fluid, but their amount is, but their the extent of its presence is comparatively less. Okay, so our answer for our question is sodium. Okay, so moving on to the next question. A patient with metabolic acidosis will be prescribed which among the following? So this is an easy question. A patient with metabolic acidosis will be prescribed with which among the following? Okay, so what will be prescribed for a patient with metabolic acidosis? That is a question, and our options are: first one is potassium supplementation, second one is administration of sodium bicarbonate, third one is checking serum sodium level, and the final one is bronchodilators. So what is the answer? So which one will be prescribed for a patient with metabolic acidosis? So our answer is definitely that is sodium bicarbonate. Okay, so we will see in detail. So we know that the metabolic acidosis results from excessive absorption of or retention of acid or excessive excretion of bicarbonate. Okay, so acidosis is resulting from excessive absorption of the acid or excessive retention of the acid or excessive excretion of bicarbonate. So as a result, what will happen? A base is needed to neutralize. Right, so a base is needed to neutralize. So sodium bicarbonate is a base and it can be used to treat the documented metabolic acidosis. Okay, acidosis is often accompanied by hyperkalemia. So why potassium supplementation is not an answer for our question is explained here. Acidosis is often accompanied by hyperkalemia. So if we are providing potassium supplementations, again the patient condition will become very pathetic. Okay, so and another option, one of the least recognized side effects of the salbutamol treatment, that is bronchodilators, is metabolic acidosis due to development of lactic acidosis. Okay, so because of the development of lactic acidosis with the use of salbutamol, there are chances for the metabolic acidosis in patients receiving bronchodilators. Okay, so don't give bronchodilators as a treatment for metabolic acidosis. Clear? So the answer for our question is metabolic acidosis. What to be given? We have to give sodium bicarbonate, and it is a base to neutralize. Okay, so moving on to the next question. Which of the following is a risk of long-term 100% oxygen? Okay, which of the following is a risk of long-term 100% oxygen? So your options are: the first one is oxygen toxicity, the second one is cerebral edema, third option is cyanosis, and final option is hypercapnia. So it's an important question and it is a repeatedly asked question. So which of the following is a risk of long-term 100% oxygen? So what is the answer? So the answer is oxygen toxicity. Okay, oxygen toxicity. So we will see it in detail. So breathing oxygen at higher than normal partial pressure leads to hyperoxia. Hyperoxia means that increased concentration of oxygen in the tissues. Okay, and it can cause oxygen toxicity or oxygen poisoning. Okay, if we are getting an option like oxygen poisoning or oxygen toxicity, both are same. Okay, so breathing oxygen at higher than normal partial pressure leads to hyperoxia and it can cause oxygen toxicity or oxygen poisoning. Okay, so who all are at risk for oxygen toxicity? So this oxygen toxicity risk are more with the patients receiving hyperbaric oxygen therapy and patients exposed to prolonged high levels of oxygen, then premature infants and underwater divers. Okay, so these are the population who are at risk for oxygen toxicity. I'll repeat, that is hyperbaric oxygen therapy patients exposed to prolonged high levels of oxygen, and premature infants and underwater divers. Okay, so how this oxygen toxicity manifest? So this may damage the pulmonary epithelium. Okay, so our pulmonary epithelium will be damaged, and this one will inactivate the surfactant. So you know the role of surfactant in the respiratory system. So it will inactivate the surfactant and it forms intra-alveolar edema. Okay, intra-alveolar edema will be developed. Then as a result, the interstitial thickening, and finally fibrosis will happen, and ultimately it will lead to pulmonary atelectasis. That is, the collapse of the alveoli will happen because of continuous high partial pressure of oxygen therapy. Okay, so this is the pathophysiology. So it will damage the pulmonary epithelium, it will inactivate the surfactant, and it will form intra-alveolar edema. As a result, there will be interstitial thickening and fibrosis will develop, and finally it will lead to pulmonary atelectasis. So this is the pathophysiology of oxygen toxicity or oxygen poisoning. Clear, no? So Moving on to the next important question from the waste management process. So the question is, the first step in the waste management process is. So the first step in the waste management process is. So you know that still we will see the options. So our options are, the first one is transportation, the second one is collection and storage, the third one is segregation, and the final one is treatment and disposal. So which is the first step in the waste management process. So the first step usually happens at the origin, okay, where the waste are originated, especially like ICUs, wards, hospital settings, etc. So what is the answer? So the first step in the waste management process is segregation. So the steps include, first one is the segregation. Segregation should happen at the point of waste development. Okay, at the point of waste development. For example, in the ICUs, clinical settings, etc. Then the next steps include the collection and storage. So first step is the segregation, the second step is the collection and storage, the third one is the transportation, then final step is the treatment and disposal. So these are the steps involved in the waste management process. First one is segregation, the second one is collection and storage, third one is transportation, and the final one is treatment and disposal. Okay, so I think it is clear for you. Now we will move on to the next question, and the next question is from some care bundles. Okay, so whenever you are working in an ICU setup, there we have to follow some care bundles. Okay, so if you are attending some interviews and all, you will definitely get a question, or we can expect such questions in our competitive exams also. This is such a question from the care bundles, and the question is, care bundles associated with the central line care is called what? So the care bundles associated with central line care is. So your options are, first one is the CLABIS, CLABIS. The second option is the CLABSI, that is CLABSI. The third one is CAUTI, CAUTI, and the final option is CAUTION, CAUTION. Okay, so what is the answer for the care bundles associated with the central line care? So what is the answer? So definitely it is CLABSI or CLABSI. So what's CLABSI stands for? So bundles for the prevention of central line associated bloodstream infection. So the CLABSI stands for central line associated bloodstream infections. Okay, so each ICUs will have certain protocols for the central line insertion, central line care, central line dressing, central line removal, everything. Okay, so all these things are aimed at reducing the infections associated with the central line infection. Okay, central line insertion. Okay, so these are the guidelines for preventing bloodstream infections related to central line insertions. Okay, so then other options, we will see the other options. The first option is just for confusing you, and the second option is a CAUTI. What is CAUTI? CAUTI is catheter associated urinary tract infection. Okay, CAUTI stands for catheter associated urinary tract infection, and the final option is the CAUTION. What is CAUTION? CAUTION. You know that CAUTION is a synonym for the 6 warning signs of cancer. Okay, now I am not going in depth about CAUTION. So CAUTION stands for that those are the 6 warning signs of cancer. Okay, so the answer for our question here is CLABSI, that is central line associated bloodstream infections. So moving on to the next question. Yeah, this is from the gastro ICUs. Okay, who have worked in the gastro ICUs can answer very fast this question. So to check for the paralytic ileus postoperatively, which of the following should be done? Okay, so question is very clear. So usually after the gastric surgeries and all, we have to check for the development of complications. So one of such complications is the paralytic ileus. So to check for the development of paralytic ileus postoperatively, which of the following should be done? So your options are, first one is monitor for the renal functions. The second option, auscultate for the bowel sounds every 4 hours. Third option, administer antibiotics. And the final option, observe and monitor patient heart rate. So which one to be checked for finding out whether the paralytic ileus like complications are happening in patients underwent gastric surgeries? So what is the answer? So our answer is auscultate for bowel sounds every 4 hours. auscultate for bowel sounds for every 4 hours. So we will see what is a paralytic ileus. You know that paralytic ileus is an obstruction of the intestine due to paralysis of the intestinal muscles. Okay, so because of the surgery or because of some other reasons, there will be paralysis of their intestinal muscles, which can lead to the obstruction in the intestine, and this is termed as paralytic ileus. So we will see the pathophysiology in brief. The intestinal muscles must be so inactive that it prevents the passage of the food, and it leads to a functional blockage of the intestine. So it inhibits propulsive bowel movement and hence frequently needs to be assessed. Okay, so you understood what I have told, and so it is very clear that in paralytic ileus what is happening is the intestinal muscles are getting paralyzed, and it results in the stagnation of the food, and it will lead to the functional blockage of the intestine. Okay, so this need to be assessed with the help of bowel sounds. So what will happen is in paralytic ileus that bowel sounds will be absent. Okay, the propulsive bowel movement will not be there, so we need to assess for the presence of bowel sounds. If it is not there, then we have to find out what is the reason through other investigations. Okay, so moving on to the next question from the ventilator settings. The question is, high PEEP in the ventilator settings can cause dash. So if you are keeping PEEP in a higher level, what will be the end results? High PEEP in the ventilator settings can cause dash. So the options are, first one is hypotension, the second one is hypertension, the third option is hyperthermia, and the final option is hypothermia. So what will happen if we keep high PEEP in ventilator settings? That is a question. It's a direct question. So what is the answer? So the answer is hypotension. So why hypotension if we keep high PEEP? So what is a PEEP? I'll explain what is PEEP first. That positive end expiratory pressure of the PEEP is the positive pressure that will remain in the airways at the end of the respiratory cycle. Okay, that is at the end of the exhalation. Okay, what is a PEEP? It is the positive pressure that will remain in the airways at the end of the respiratory cycle. So so this PEEP is the thing that keeps our alveoli intact, alveoli open. Otherwise what will happen? Atelectasis will happen. So that is the reason we are keeping a considerable amount of value of PEEP in the ventilator settings. And this positive pressure, what we have told, it is greater than the atmospheric pressure in mechanically ventilated patients. So as a result, there won't happen any collapse of the alveoli. So that is the function of PEEP. So what will happen if we keep high PEEP? High PEEP can lead to barotrauma. There will happen barotrauma, that pressure trauma will be there for the alveoli, and there it results in a drop in cardiac output. So how this barotrauma can result in a drop in cardiac output, that we have to see. So with each respiratory cycle, what will happen is the amount of air trapping increases. Okay, the amount of airs that are trapped inside the alveoli will be increased because we have kept the PEEP on the higher side. So what will happen is consequently the intrathoracic pressure increases pathologically. There will be pathological increase of the intrathoracic pressure, and it will compress on the right atrium, and as a result what will happen? There will be decreasing venous return. The venous return to the right atrium will be decreased and thus causes hypotension. So this is the pathophysiology for the development of hypotension if we are keeping high PEEP. I repeat, so with each respiratory cycle what will happen is, with high PEEP the amount of air that is trapping inside will be more, and as a result the intrathoracic pressure will increase pathologically and it will compress the right atrium, and as a result there will be decreased venous return which causes hypotension. So it's clear for you. So moving on to the next question. The next question is from the triage system. Okay, so triage also is very, very important, especially in the emergency settings and all. So our question is from the triage. So here is your question. Transferring the patient to the operating room or the intensive care unit comes under which stage of triage? So the question is, transferring to the operating room or the intensive care unit comes under which stage of triage? And your options are, the first one is the primary stage, second one is secondary stage, third one is the third stage, and the final one is all the options mentioned above. So which is the stage in which the patient is transferred to the intensive care unit or the operating room? So what is the answer? So the answer is, it is in the third stage of triage. So we will see the stages of triage in brief. So you know that the triage is usually performed at 3 stages. Okay, the primary stage, the secondary stage, and the third stage. Okay, the primary triage is happening at the scene of the incident. Okay, this triage is carried out at the scene of the incident by an emergency technician, aims at the prompt assessment of the injured person and rapid transfer to the treatment center. Okay, so this if something happens in a particular site, in that site the emergency technician will be assessing the patient and the prompt assessment will be done and the injured patients will be transferred to the treatment center. So the assessment, what is happening at the scene of the incident, is known as the primary triage. Okay, and now comes to the secondary triage, which is used when, due to the large extent of the incident and lack of resources in the pre-hospital, that means in the injured site, the transmission of the injured person has been prolonged in the scene. Okay, so in these cases, triage will be done by an emergency doctor or surgeon as soon as the injured person arrives at the hospital. Okay, so when the patient arrives at the hospital, so the surgeon or the emergency doctor will decide what to be done with the patient. Okay, so that point of triage is termed as a secondary triage. Okay, so the primary triage will happen at the scene of incident. Secondary triage happens when the patient reaches the hospital and the doctor decide what to do with the patient. And the question for our answer, that is the third triage, is performed to prioritize and decide on receiving care services. That means including the transferring to the operating room or to the intensive care unit. Okay, so in the second stage, what will happen is that doctor or the surgeon will be identifying which patient will be required more care. Okay, in the third stage, what will happen is that more care will be provided in specialized areas like operating room. If the patient requires operation, then patient will be shifted to operating room, or if the patient requires ventilation or mechanical ventilation or ICU support, patient will be transferred to the intensive care unit. Okay, so this step will be done by a surgeon or a critical care specialist. Okay, so it is clear for you the three stages of triaging. Okay, so moving on to the next question. So this is from the pediatric emergency, pediatric intensive care unit. You are working in the pediatric setup can answer this question very easily. So the question is, failure to pass meconium within 48 hours of birth in a newborn with no obvious external abnormality should lead to the suspicion of. So the question is very clear. If the baby didn't pass meconium for within the first 48 hours of the birth, so, and if there is no other problems, then what we should suspect. Okay, so question is very clear. Failure to pass meconium within 48 hours of birth in a newborn with no obvious external abnormality should lead to the suspicion of. So here comes the options. So the first one is the anal atresia. The second option is congenital pouch colon. The third one is the congenital aganglionosis, and the final one is the meconium ileus. So what is the answer? So you know that the answer is congenital aganglionosis, or otherwise known as the Hirschsprung's disease or HD. So Hirschsprung's disease or the congenital aganglionosis is a motor disorder of the gut which is caused by the failure of neural crest cells to migrate completely during the intestinal development during fetal life. So what is this neural crest cells? You know that the that ganglionic cells are the cells which are responding to the responding to the nerve stimulation. So it's when to pass and the contractions, peristalsis, everything will be controlled by these ganglion cells. So these ganglion cells are formed from where? It is formed from the neural crest cells. So in Hirschsprung's disease, what is happening is there will be failure of the formation of neural crest cells, which will result in the improper development of the enteric ganglionic cells, and it will migrate completely and it is happening during the intestinal development during the fetal life. Okay, so what will happen as a result? The resulting aganglionic segment of the colon fails to relax, causing a functional obstruction. Okay, so it won't respond. That particular portion of the particular segment of the this one won't respond and it fails to relax, causing functional obstruction. So that is Hirschsprung's disease, and as a result the baby will be presented like the baby won't pass meconium for the within the first 48 hours of birth. Okay, And we know that in other options like imperforate anus. What is imperforate anus or anal atresia? It is a congenital anorectal malformation or ARM, where a normal anal opening is absent at the birth. Okay, there is no anal opening for the baby. Okay, that is imperforate anus or anal atresia. Then the another option was the congenital pouch colon. What is the CPC or congenital pouch colon? So it is an unusual abnormality in which a pouch-like dilatation of a shortened colon is associated with an anorectal malformation. So this is also an anorectal malformation, and here what is happening is there is an unusual abnormality in which a pouch-like dilatation of a shortened colon is present. Okay, so that is congenital pouch colon. Then the last option was meconium ileus. So what is meconium ileus? It is a bowel obstruction that occurs when the meconium in child's intestine is even thicker and stickier than normal meconium, and as a result it will create a blockage in the ileum. Okay, so the meconium will be more thicker and more stickier than normal, and it will result in the blockage of the ileum, which is termed as meconium ileus. Okay, so the other options are clear for you now, and we will move on to the next question. It is regarding the acute lung injury or the ARDS. Okay, so in patients with worsening acute lung injury, which among the following should be considered to improve outcome? So to improve the symptoms of acute lung injury, what a nurse should do? That is the question. So here comes the options. Provide prone position to the patient. Then the second option is conservative fluid management. Third one is search for other diagnosis, and final one is search for and treat undiagnosed underlying conditions. So what is the answer? Prone position, conservative fluid management, search for other diagnosis, search for and treat undiagnosed underlying condition. So what is the answer? So here the answer for our question is prone positioning. So how prone position will improve the symptoms of ARDS, that we will see in detail. So for patients with moderate or severe ARDS or acute lung injury, prone positioning was recommended for at least 12 hours per day. 12 hours per day, that is important. For patients with moderate or severe ARDS, prone positioning was recommended for at least 12 hours in a day. And in ARDS, there will be, what is happening in ARDS is there will be an imbalance between blood and the air flow. Okay, there occurs an imbalance between blood and air flow, and as a result what will happen? It will lead to poor gas exchange. Okay, so proper gaseous exchange won't happen in ARDS patients. So what will happen if we provide prone position? So while providing prone position, there will be redistribution of the blood and air flow more evenly, and it will reduce the imbalance and improve the gas exchange. Okay, so this is happening if you are providing prone position. Okay, so there will be imbalance in the blood and air flow in the patients with ARDS. So if you are providing the prone position, there will be redistribution of blood and air flow more evenly, and this will rectify the imbalance and improve the gas exchange. Okay, so that is the answer for our question. So next question also is very, very important. Incentive spirometry after the surgery helps to prevent dash. So in the ICU setups and all, we know that we used to provide incentive spirometer to the patients for some reason. So what is the reason? Incentive spirometry after surgery helps to prevent dash. So your options are, first one is lung collapse, the second one is gastric and intestinal problems, the third one is elevated blood pressure, and the final one is blood clotting. So how incentive spirometer helps to prevent one of these options what we are given here? So what is the answer? So the answer is lung collapse. Incentive spirometer after the surgery helps to prevent lung collapse. How? So you know that a spirometer is used to help the lungs regain their strength. Okay, because of the surgery, because of the anesthesia effect, and because of the lack of immobility and all, there will be the strength of the lungs will be gone. The strength will be diminished. So to restore the functions of the strength of the lungs, the spirometer can help a lot. So normally 10 to 15 breaths with the spirometer every 1 to 2 hours is prescribed for postoperative patients. Okay, so what is a normal spirometer? exercise rate, it should be 10 to 15 breaths with the spirometer every 1 to 2 hours is prescribed. Okay, so the answer is very clear, to prevent lung injury or the lung collapse. So moving on to our next question. It's a very important question and it is little confusing also. I think this is our last question for this session. So what is the ideal time interval for patient monitoring in the post anesthesia care unit? Okay, question should be very, you should be very vigilant about this question. The question is asked in post anesthesia care unit, that is PACU, that is post anesthesia care unit, not in the surgical ICU or ICU. Okay, so what is the ideal time interval for patient monitoring in the post anesthesia care unit? So here comes the options. We have to monitor every hourly, every 15 minutes, every 30 minutes, or every 10 minutes. So these are the options: every hour, every 15 minutes, every 30 minutes, and every 10 minutes. So what is the answer? So the answer is every 15 minutes. Okay, so we will see why every 15 minutes. You know that usually the patient remains in PACU, that is post anesthesia care unit, for 60 to 90 minutes. That means nearly 1 to 1.5 hours after the surgery, depending upon the patient's response. Okay, so post anesthesia care unit is a place where we used to keep the patient for around 1 to 1.5 hours to get out of the effects of anesthesia and so it is a short term period the patient will be in that unit. Okay, so the vitals like heart rate, body temperature, oxygen levels, and ensuring airways need to be constantly monitored. Okay, it should be constantly monitored in the immediate post-op period. Okay, so the immediate post-op period, these vital parameters should be constantly monitored. So in our options, what we have, the minimum time interval was 15 minutes. So we have to choose that option, like that is every 15 minutes we have to monitor the patients for the vital parameters like heart rate, body temperature, oxygen levels, and airway assessment. Okay, so that is the answer. So so far we have discussed around 15, almost 15 questions from different aspects in the intensive care units, and which includes the ventilator and pediatric ICUs, gastric ICUs, everywhere. Okay, so these questions are very, very important, and I hope these questions helps you a lot in gaining more knowledge about these topics. So kindly stay tuned and we will come with the second part of this ICU series. So thank you for watching the video, and stay tuned. See you soon with another video very shortly. Thank you.